leader who's kind of crafted the Healthier Aging series and will introduce today's program.
Oh, you need to unmute.
Yes. Okay. Good afternoon, everyone. Thank you, Avi, and welcome to our Healthier Aging Spring Health and Wellness presentation. It's really great to see so many of you here today for this important topic. Before we begin our formal talk, though, I would like to take just a little time to let you all know about some of our other healthier aging activities, and particularly about our spring plans in the hope that we can entice you all to get on the move again. You know, we all know that the pandemic with its forced isolation over the last 2 years has made it really hard for some of us to be as active as we might have liked. We have spent so much time sitting in front of our computers, our TV, and even though we've seen and learned a lot, it's really not been great, as you know, for our overall health and fitness. So now that the pandemic seems to be receding, we hope you will all feel safer getting out and about and will join us with other Ashby Village members and volunteers for some fun fitness activities. I think we have some pretty terrific activities planned. Just tomorrow at 1 o'clock, we have a hike planned at Inspiration Point in Tilden, and it's not too late for you to join us at Tilden Park at Inspiration Point at 1 o'clock. On March 14th, we'll be meeting at Arrowhead Marsh in Oakland for an easy and a flat walk. And on March 23rd, we'll be hiking on the Seaview Trail in Tilden Park, one of my very favorite hikes where there are great views and maybe even by then some wildflowers to be seen. All of these hikes start at 1 o'clock and usually end by 3. And you can find out more about our hikes and our classes and how to register for them by going to our newsletter or our weekly events calendar. But if hiking is not your thing, 2 of our fitness classes have survived online during the pandemic. Our aerobics class with Ann Aronoff meets Wednesdays at 10 a.m. and our yoga class with Nancy Yates meets on Thursday at 10 a.m. Both classes will continue online through June and are really great ways to stretch and improve our balance. We are, however, really hoping that all our classes will soon be available in person, and we are working on new classes in collaboration with the Albany Y. So join us and let's all get moving again. Exercise is truly so good for your health, as you all know, and in so many different ways. Jeanette Ward, who unfortunately cannot be here today, is my co-leader, and we would both love to hear from you if you have topics you'd like for us to present at our wellness presentation or classes you might like to have. And Jessica will be putting both of our contacts in the chat, so please feel free to reach out to us and let us know what you would be liking to see and do. And last but certainly not least, I want to let you know that on Sunday, March 27th from 2 to 4 p.m., the Arts and Culture and Healthier Aging teams will be so honored to co-host Dr. Louise Aronson, author of the Pulitzer Prize nominated book, Elderhood, who will speak to us about aging and ageism. And I want to say that this will be a really important talk for all of us who care about not only how we age, but what improvements are needed in both our medical system and our society in general to make sure that the last third of our lives, what Dr. Aronson calls elderhood, can be lived with appropriate medical care and in a comfortable and safe environment. And believe it or not, with us all living longer lives, many of us really do live a third of our lives in elderhood. So save the date. She's a great speaker with a wealth of important information to share with us. And now I am very privileged to introduce Dr. Stephanie Marquet to speak with us about hospice and palliative care, a topic that is not often well understood, but is so important for all of us to understand better as we age or suffer from chronic illness and pain. Dr. Marquet has had a very long interest in end-of-life issues and palliative care. She's a graduate of UC Davis Medical School and has practiced at Kaiser Permanente of the East Bay for over 20 years, where she championed advanced care planning and led an early movement to train inpatient staff in end-of-life care. She also taught her fellow staff about communication skills for staff working in culturally diverse communities. She has served as a palliative care attending physician and as hospice medical director and home health medical director at Kaiser. She joined the Hospice of the East Bay in 2020, where she now serves as the founding hospice director. She lives in Albany with her husband and 3 children and her mother next door. Welcome to you, Dr. Marquet.
Hello, everyone. All right, this is where I need to share my screen. Bear with me a moment. All right. All right, this is, I'm just going to proceed. First of all, hello, everybody. I'm just so excited to be here. Slight correction, I am not the founding medical director of Hospice East Bay. Hospice East Bay has been around for a long time, since 1977. I currently serve as associate hospice medical director. Well, let me start by saying thank you all for having me. This is actually a really exciting day for me. I was reflecting and getting ready for this talk and realized this is the first community talk that I have done since COVID hit. It's amazing these past 2 years, the changes that have happened. And there was just so much energy and need to do education in the hospitals, in the nursing homes, in the care homes, that for me, this is kind of a representation that we are in a better place. COVID is still here. It's been difficult times. But again, I'm thrilled to be here giving a community talk. Thank you very much to Ashby Village for having me, specifically to Roberta, who helped me with the back and forth and making sure that all the equipment is working. I'm going to be talking today about hospice and palliative care, but also kind of clarity and choice at the end of life. I'd like to take a moment to thank Hospice East Bay, where I currently work. As I said, I'm one of the associate hospice directors. I'm also the attending of the new expansion team that Hospice East Bay has in Alameda County. So I'm really excited. I'm actually a clinician. I drive around Alameda County visiting our patients. We expanded about a year ago and have seen a lot of growth, and we're building connections into the community. At the end of the talk, I'll speak a little bit more, but we're a nonprofit organization I'm really proud to represent today. So in terms of what I'm going to be talking about, we're going to talk about dying. I think it's important, it's an essential topic. It's something we all need to normalize. I'm going to go into some trajectories of decline to kind of set the context. I'm going to talk about goal-oriented care because it's a movement in palliative care and hospice. Just touch on some of the options around dying, and then touch on hospice and palliative care. And there'll be a lot of time for Q&A. That's always the most interesting part. Oh, I had missed this slide. This is the little bit of a slide of me, and this is me and my mom. And I put this slide in because I just wanted folks to know that this is not just a professional interest of mine, it's a personal one. I grew up in a community that was full of older people, grandparents and their friends, and I'm very much drawn to this work because of my lived experience. So this is my mom, she's a sweetie. I live in Albany and she is in Kensington. All right, this is a funny slide to start. This is a slide I actually made over 20 years ago when I was in residency. And it's meant to introduce a little bit of humor and to have us all settle into the idea that while many things have changed in the past 100 years, some things have not. And the reality that we all die is just something that we live with. It's very natural, it's part of life, it's part of the life cycle. And yes, it is true that we will all die. That being said, I want to acknowledge that it can be a very difficult topic for some people. And there's complex reasons to that. I personally, and for those of us in the field, when you look back in time, you can see that death used to be very much normalized. You kind of born, went through the life cycle, and at the end of life died. But that was back in the day when families tended to be more intact as multi-generations living in one place. And there was just more bandwidth, I think, for this kind of personal care that modern life is having a hard time holding on to. So the reasons death is hard for us to talk about are cultural. It's also about family norms. Every family has their own way. Some families, they talk about it all the time and some don't. People have specific religious beliefs. Sometimes, and actually more often than I think, or I think it's a topic we should talk about more often, there's actually guilt and fear about not having time to repair some of the mistakes we've made in our lives. And we've all wronged some people, and that can make looking at death a little bit scary. In general, and part of this talk today is I encourage everybody to just talk about it. Share with your family and friends your hopes, your fears, your ideas. In sharing our lived experience, I think is the best way to get a sense of how to both live well and create energy for living well, even if you are facing serious disease. And that's really the goal, isn't it? All right, so we're gonna talk a little bit about what is this word dying and what is this word terminal illness. You'll hear it, doctors will say it, you have a terminal illness. Well, what does that mean? You know, am I dying now? Am I dying today? Am I dying tomorrow? Aren't we all dying? It's kind of like an existential question. But it is important to get a sense of how much time does one have if a doctor is trying to give you news that you have a serious illness. I have found what most people want is a sense of, well, how much time do I have? What are you trying to tell me? And you'll realize as you start to have conversations with your physician that your physician may still be being vaguer than you want them to be. And that is honestly because it is hard to know when a person is dying. And by that, I mean that there are not good prognostic tools for clinicians like myself to draw upon, to type in all the variables and have a number pop out that says, this is what I mean when I say you have a terminal disease and this is how much time you have left. It actually can be very hard for clinicians to know. So instead, what we tend to use is these buckets. And we think of somebody who is living with serious disease as being in a certain bucket of how much time do they have. And I thought it would be helpful just to share the language that we use among ourselves. So we talk about years. It's kind of the biggest bucket is somebody is going to have years of life. Months to a year. It can be harder to be more specific than that. For hospice eligibility, you'll hear 6 months or less. And then weeks to months. So time is really getting shorter. A person is having a lot of symptoms. Weeks to months, days to weeks. Now a person is really getting closer to their end. And then actively dying, and by that we mean hours to days. In hospice and in palliative care, we tend to reserve the word dying to mean really close to the end, meaning weeks to days. And the reason we do that is because in hospice and palliative care, we're focusing on living. Yes, we are all dying, but we're not dying today. At Hospice East Bay today, I think we have 290 patients under our care, and they're all alive and they're all living, and we want them to have the best lives that they can. So I like to use the word living with serious illness to give room and opportunity to have discussions that explore well-being. What is it that a person wants to focus on in this time that they have? I do find it helpful as we talk about serious illness to look at the trajectories of decline, and there's 4. This graph only has 3 lines, and that's because I didn't include the graph of when a person suddenly dies, like in a car accident. That's obviously just like in a moment. But other than that, in hospice and palliative care, we frequently talk about trajectories of decline. So a person can kind of have a sense of, well, what's going to happen? What is this going to look like? And of course, there is no one graph that's going to explain all the different ways that a person moves through their serious illness, but it is helpful to have some sense of the different ideas. The red line is what I would call a classic cancer trajectory. And some people get their diagnosis very upstream, meaning they live with cancer for years and they're out in the community, they're driving, they're doing what they want to do. Some folks get their cancer diagnosis actually when the disease is very advanced and their time is quite short. But in general, if your cancer has been diagnosed upstream, there may be quite a bit of time when you're living fairly well and your functional status is fairly preserved. But at a certain point, if the cancer is not treatable and is advancing, there will be a time when the complications start to accelerate and start to show up. So there's one, then there's two, there's more and more complications developing. And that's kind of where we see a person's functional ability and disease burden and symptom burden really increase. And that's where the red line starts to dip down and the physicians can start to, or probably would start to talk about goals of care and pulling back on treatment to prepare for the end of life. So that's one trajectory. The blue line that kind of goes, has this sawtooth up and down, but even though it goes up and down, it's actually like getting lower with each time. That's a trajectory classic for organ failure. So let's say a classic being the heart or the lung. So a lot of emphysema, a lot of lung disease or heart disease. Heart failure is a classic. Where a person has good quality of life, but they've, and say heart failure. You're on some medications, you're doing well, but when your heart failure is flaring, meaning you're in an acute episode, your health status goes down. You might even need to be hospitalized, but you can recover from that and you bounce back, but maybe not to the level you were before. Maybe all the time in the hospital bed or just the time that it took you to recover took a toll, and now your functional level is a bit lower than it was before. And this kind of going in and out of the hospital or in and out of an acute problem is par for the course. And at one of those dips, it is likely going to be the end of your life. And honestly, it can be hard to know which of those dips is the one that is causing your death. And that also adds confusion to this whole thing, as people often prefer to have some advance notice that this is happening. But even sometimes the clinician is not sure. We've had plenty of folks who come onto hospice, who out of the hospital, who we think are actively dying, and then boom, with some really good care, some really good focus on the right medication regimen, they actually turn out to be on the upswing and have graduated from hospice. The last line, the green line, is a neurological decline. So neurodegenerative diseases of all kinds, the dementias, the Parkinson's, can have what we associate more with the dwindles, where the baseline functional status is actually could be very, very low, but they might live for years with attentive care. And that's kind of why the green line is lower, is that what I'm talking about is when the quality of life or when the functional status and cognitive status is very low, a person can still live quite a long time. And it also can be hard to predict when somebody is actually moving towards actively dying. In terms of what we die from, I just put up some data that is from the National Hospice and Palliative Care Organization that was looking at hospice deaths in 2017 and 2018, and cancer is still the #1 referral for hospice, followed by circulatory heart diseases, and third is dementia. But I have to say dementia is the fastest growing, or is having the most change year by year in terms of the number of referrals. Okay, I'd like to segue and start to talk about goal-oriented care. What is it? What do I mean by that? And my goal for this talk, one of the main goals, is to encourage everybody to start thinking not just about advanced care planning, but but to this broader idea of goal-directed care, which is this sense of a person and a family unit at the center, and that everybody who's important to them, including their medical team, know who they are, what's important to them, and then match their values and their sense of self to their medical plan. So it's a really beautiful model that is having a lot of success at helping people have the health outcomes that is congruent to what their wishes are. So what I mean by goal-directed care really is, I think of it as in three parts. And the first part is advanced care planning. That's a fairly upstream process where there's documents to fill out, and I hope you have all done this. But it is where you assign a surrogate decision maker. It can also be referred to as a healthcare proxy. There's many different words, but basically advanced care planning is a series of documents where you outline kind of the broad vision of who's going to speak for me if I can't speak for myself, and maybe include some broad brushstrokes of, I never want to be on a ventilator if I'm not going to be able to recognize my family. In this category would be the POLST, and I'm sorry, I should have put a picture of it. Hopefully you guys are familiar with the POLST, the Physician Order for Life-Sustaining Treatment. That's a document that you can actually put in your home and on your fridge that outlines some basics of your healthcare wishes that folks like paramedics who enter your home, if you call 911, that they can follow what's on that piece of paper. And the recommendations are that anybody over 50 have some documents of advanced care planning. Anybody over 50, or upstream of that, anybody living with serious illness. The second tier is actually where I spend the most of my time, and these are goals of care discussions, and they're different. And I think it's important to know that something like a POLST is a very generic document, but a goals of care discussion is the opposite. It's a very detailed discussion where you actually do scenario planning with the disease that you have, with the serious illness that you are living with, that you have discussions with your healthcare team as you visualize what might happen. You're kind of keeping in mind those different trajectories of decline to say, well, at a certain point, I might not want, for example, chemotherapy, right? If chemotherapy is causing you benefit and it is giving you more time and the burden of the side effects is low, sure, people are going to go for chemotherapy. But looking forward to say, well, there may come a time when even with chemotherapy, my disease is still progressing. Now I might need different kinds of treatments. And if those treatments, if I feel lousy all the time, I'm not going to want those treatments to continue. So goals of care discussion is kind of these ongoing discussions, and I would have them not just with your physicians, but with the people who are listed in your advanced care directive as well, so that they understand what your wishes are. And it's important to start to get specific as well. And then the bottom of the pyramid where it all comes together is where you have done your homework, you have filled out, you have thought about it, you have brought living with serious illness, you have held it, worked with it, talked about it with your friends, your family, your doctors. And now at the bottom of the triangle is when you are in the treatment planning phase. Your physician is outlining what your treatment options are, and you are choosing. So this is where you might say, no, that third trial of chemotherapy, I don't want to do it. The others were really burdensome. I don't want to do that again. I'm actually ready to talk about what other options are available for me. I'm thinking about hospice. So this to me is a really beautiful model of a way to think about what we all need to be doing to keep everybody around us informed about what our healthcare wishes are. And this is just a slide to show how few of us actually do it. And in this audience today, I bet there are more PhDs and advanced degrees than in most Zooms of 100+ people, or however many we are. But I bet the data would show that half of you at least don't have it, even an advanced directive, and possibly only a third nationwide. So really surprising data there. And there is clear data that shows when you do your goals of care and your advanced directives, it's a gift you give yourself, and especially it's a gift you give your family. I think across the board, people don't want to be a burden to their family. That's just something we hold as a core value. And letting the people around you know what kind of health care you want when you get sick is really, really important. So I'd encourage you all to do it. It's so important that I thought I would just take a sec to share some of the ones that I find really helpful for advanced care planning. There's the 5 wishes. All of these are available online. The Conversation Project is a fantastic initiative from the Institute for Healthcare Improvement out of Washington. I was really sad when Get Your Shit Together changed their name to CAKE. And it's kind of have your cake and eat it too. Do your planning and live the best you can. That's why they renamed it CAKE. And this is BJ Miller from San Francisco Palliative Care Department. He's a part of this project. If you're a Kaiser member, there's fantastic tools that will get scanned directly into your medical record. I wanted to take a second. Sometimes I get questions about advanced directives specifically for dementia patients to address feeding or not feeding if a person has very advanced dementia where they don't recognize their family and may not even know how to use a spoon anymore. There are some advanced directives that do have an added sheet to specifically address advanced dementia. One that I like that's very clear is End of Life Choices New York. I will have to say, and I'm not up to date on this, I'm not in terms of the legalese, but these advanced directives are controversial how much they can be followed if somebody says, don't feed me if I don't pick up a spoon. I wanted to touch a little bit on options. I think it's important to talk about. And again, all of this talk is to encourage you to talk to your medical team, to create time to have these discussions with your doctors, nurse practitioners, whoever it is part of your team. But when somebody is living with a serious life-limiting illness, there's still lots of options for a person to think about. For some people, it's do everything you can. And for some people, it's do everything you can, even if the quality of my life is really low, right? There's no right or wrong of this. These are personal decisions that people have to think through. Some people may want to involve palliative care, which I'll talk about. That's a layer of support to your primary medical team that is trying to add more values-based thinking to your treatment. A lot of people are in the category of wanting selective, what I'm going to call selective treatment. And that is where you've been given a diagnosis of a serious illness, but there are a plethora of treatment options available to you because that's modern medicine. It's a miracle. Look how long we live now and how healthy we can live. But there may be some treatments that you know are burdensome that you don't want. A classic one is being on a ventilator for a prolonged period, especially if you are not that awake. So a lot of people more and more are saying, yes, I want treatments for my disease, but there's certain things that I just would find too toxic and I wouldn't want to do that. And for some people, as part of that, they say, and when I'm ready, when I'm closer to dying, then I'll go to hospice. And this can be with or without palliative care. Some folks, when they're given a diagnosis of a serious life-limiting illness, some of them are like, you know what, I'm ready for hospice now. They're not interested in going to the hospital. They're not interested in more tests. They've kind of been through that before. And they say, no, I'm ready for hospice now. And that's a fine way to go too. Voluntary cessation of eating and drinking, I just wanted to put it on here. It's something that you'll read about or hear about periodically. Very few people actually do it. It's really hard to do. It's really hard to not drink when your body is thirsty. So it's actually something that very few people actually do. And honestly, I couldn't recommend it because it is so hard to do. The End of Life Options Act is something that became legal in 2016, signed by law by Governor Jerry Brown, that allows a terminally ill patient or a terminally ill person who's been given a diagnosis by 2 physicians of 6 months or less can opt to work with a specialized physician to have a prescription for a lethal cocktail of medications that they ingest and die that day. I'm gonna segue towards talking about hospice and palliative care. And I've always liked this slide. It kind of tries to put all of us on this little slide, and it's to say, just to kind of show the different stages, and that so if you are living with serious illness and you want to get the best care possible, the idea is that you are using the treatments that are available and offered to you to have the best quality of life you can. But as your symptom burden goes up through time, that's the dotted line, as your symptom burden might be going up, to start to engage palliative care to say, okay, well, yes, I really want to have the best life possible, but here's what having a good life means to me. And that's really what palliative care is trying to do, is to make these discussions personal, because what is a good life to me may not be what a good life is to you. Some people are very tolerant of a high burden of symptoms and other people are not. And some of this has to do with how old you are. Some folks who are 100 are sometimes not that excited to get to 102, whereas for some people, that's their biggest wish, is to get to 100. So we're all different. But at a certain point, when the physicians are telling you that the treatment options are no longer working and there are no more treatment options, that's a time where some people start to think about hospice, which is really to focus on end-of-life care. And beyond that, of course, is grief work and bereavement work, which is a whole nother talk, and really beautiful work that is a part of hospice and palliative care. All right, full disclosure, I love hospice. I always have. I'm not quite sure how I came to be so enamored with this phase of life, but I just find it so rich. I like working with people who are facing their end of life. It gives me opportunities to have such real, frank discussions about what is important, and of all the life review, thinking of all the people a person has met and all that they have accomplished is really such beautiful work, and I feel very privileged to do it. I'm briefly going to talk about hospice care, what it is, and then I'll also talk about palliative care and do a little bit of compare and contrasting. So hospice is a word that we're all familiar with, but I actually don't think people really understand what it actually is. So hospice is a Medicare benefit. It actually kind of acts as your primary care team. You can still keep contact with your prior medical team if you want to, but most folks who come onto hospice choose to have hospice be their primary care team, meaning they can take care of absolutely anything that comes up. So it's a care program specifically designed to work with people who have 6 months to live or less, and who are choosing to focus on quality of life instead of quantity of life, and to no longer pursue curative treatment for whatever brings them to hospice. One of my favorite parts about hospice is that we focus not just on the patient, the one person, but we look at the person in the context of their community. So we're we're the only branch of hospice, of medicine really, that looks at an entire ecosystem around the person as our patients. And the great thing about hospice is that it comes to where you are. It's not a place you go to, but it is a care team that comes to you wherever you are, be it in your own home, be it in a nursing home or a care facility. What are some of the things that I love about hospice? I love that it's not just about the diagnosis and the treatment options. It's really about, what are you feeling? What is your body feeling? Are you tired? Are you nauseous? Are you short of breath? And we focus less about the diagnosis, and we focus more about, how are you feeling and what can we do to make you feel better? And it's not just how your physical body is feeling, but it's, well, how are you feeling as a person? What is your emotional state? What are your spiritual thoughts? We really get into, who are you as a person? We help people be where they want to be. A lot of people do want to be at home, but it takes a lot of work. You know, if a person is bedbound, that's a whole new skill set that caregivers are going to have to learn. And those are the type of education, or that is the type of education that we provide. We're specialists in symptom management, meaning the common ones being pain, nausea, shortness of breath. I have a host of tips and tricks that I have learned over the years and that we share at our hospice and palliative care conferences. And hospice really is an expert at providing symptom management at the end of life. And we help people hopefully live the best life that they can for the time that they have. And we definitely talk a lot about quality of life. So who is eligible? To be eligible for hospice, a person has to have a diagnosis of 6 months or less. And again, remember when I was talking about the lack of prognostic tools, your doctors might get this wrong, right? Historically, physicians have always underestimated how much time a person has left. And honestly, a statistic that makes me very sad is that 1 out of 4 hospice referrals, or 1 out of 4 people who come to hospice are only on hospice for a week, less than a week before they die. That's called a very late referral. So I always encourage folks, part of these talks and about goals of care and about just normalizing death is hospice can be a very rich experience for the person and for the family members. And we prefer to meet people earlier so we have a time to get to know each other and work together. So if a person has a prognosis of 6 months or less, they can enroll that day. One of the major differences between hospice and palliative care is how it is paid for. So hospice is a Medicare benefit. That means it is across the nation and it is defined by Medicare. And because it is a defined benefit, there is a lot of similarities between different hospice agencies. But I have to say there's also an enormous amount of difference between hospice agencies. You know, the quality of the staff, how many home health aides do they have, which medical equipment company do they contract with. But in terms of the payer, Medicare is the payer for hospice, and there are no out-of-pocket expenses unless there's stuff that you want that hospice can't provide. So some people want like a fancier hospital bed. That might be an out-of-pocket expense, but otherwise hospice covers all the medical equipment, medications, and the staff like myself who are part of your care. For folks who are not enrolled in Medicare, private insurance, most private insurances also have, like Kaiser, for folks who are not yet Medicare eligible, also has hospice as part of their insurance plan. So I'm going to talk a little bit about palliative care, and it definitely gets harder to talk about palliative care, and that's because it is not a Medicare benefit, it is much less defined. So because hospice is so well defined and palliative care is so similar to hospice, people are like, oh, palliative care must be like hospice. It is philosophically, but in every other way, it's a completely different beast. So hospice is palliative care, but not all palliative care is hospice. Palliative care can be much more upstream, much early in a person's disease trajectory, such that there's no criteria of any type of, you need to have 6 months or less. Really, palliative care is hoping to work with people very upstream so that they can start to have discussions about values, quality of life, and what to expect and do future planning. So what they have in common is the philosophy of focusing on comfort, reducing stress, offering sophisticated symptom management, as well as psychosocial relief and just holding of the whole person. A major difference is how palliative care is paid for. Different insurance agencies may have a palliative care offering, but you have to stick to your insurance umbrella to get it. So say you're a Kaiser patient, yes, you are eligible for Kaiser palliative care services, but you need to ask, well, what palliative care services does Kaiser offer? And then what about Sutter? What do they have? And the offerings can all be very different. I will say that I think now all of the hospitals in the Bay Area have palliative care as an inpatient service, meaning if you or family members ever hospitalized with a serious illness and you have questions that you feel your doctor's not really answering well enough, or you're having symptoms that you'd like to be managed a bit more specifically, palliative care is in all the hospitals of the Bay Area. The next place you'll find palliative care is in the subspecialty clinics, stuff like specifically oncology. Many, if not most, oncology clinics now have a palliative care offering, but you won't know who's part of the palliative care team. Is it a physician? Sometimes it's a social worker, and that social worker may primarily be helping with advanced care planning documents. So the variability in palliative care teams is really broad. So I would encourage you to ask your physician, your medical team, if I would ever want to be involved with or have palliative care service involved in my care, what offerings do you have as part of my health insurance? I should say, I'm not sure if I said it, but for palliative care, there's no limits about prognosis. There's also no limits about the treatments you can have. On hospice, disease-directed curative treatment is no longer an option, but on palliative care, all treatment options are still available. So for the folks who are kind of either never hospice or not hospice now, but they are living with serious illness and have a high disease burden, those are the folks that I would highly encourage to reach out to your doc to say, hey, does my insurance include a palliative care offering? And if so, can I see them? I've talked a little bit about this, but it's important enough that I thought I would just highlight it side by side. So hospice is your primary care team, and it is it's a Medicare benefit, meaning there's no out-of-pocket expenses to the family. It's total person and family care. Hospice comes to you. Hospice includes the nurse and the physician, all the medical equipment, the medical supplies, the drugs to manage your pain and your symptoms, homemaker services such as home health aides, bereavement services. One of my favorite parts of hospice is that hospice bereavement services start once a person dies. Their family, should they want to, is able to use bereavement services afterwards, which is just really important to work through grief and just often just process the experience. There is physical therapy and occupational therapy under hospice, but it's really kind of like a one-time safety check in the home to work on mobility issues. And then in contrast, palliative care is a layer of support to your medical team, meaning it's rarely a standalone, I only have a palliative care doc and they're directing my care. It's not like that. Your oncologist is directing your care, and the palliative care services would be a layer of support to you and your oncologist. And it's not a Medicare benefit, meaning it's through your insurance or fee for service. It's not a defined benefit, meaning you really are not quite sure what you're going to get, so it's good to ask. And it is an excellent, amazing layer of support to your physician team and to you to do this kind of goals of care planning, disease trajectory, understanding, as well as excellent symptom management. And as I was saying, most robust programs are in the hospital. They're growing in the subspecialty clinics. And there is movement to increasingly have home-based palliative care. Sutter has a small program, and we at Hospice East Bay also have a home-based palliative care program, although I need to let you know that we don't yet have it in Alameda County. So that is something we're hoping to grow over the next year. I'm kind of wrapping up my talk now. I wanted to tell you a little bit about Hospice East Bay because I think it's a fantastic organization. And again, in Alameda County, we are offering hospice services, but not yet palliative care services, but we'll be doing that in the months to come. And I'll let the folks know at Ashby Village, or I'll let you all know at Ashby Village when that happens, in case you're interested in seeing what services we have. So Hospice East Bay is a community-based nonprofit hospice. We're based out of Pleasant Hill, and historically since 1977 have been serving Solano and Contra Costa County, and just expanded into Alameda. It's actually been a year, but things went really slow in the beginning due to COVID. We're accredited, we're independent. It's just a really cool organization that I can't speak highly enough of. This is a map of our territory. Some of you probably have heard of us. We've been around for a long time. The other big nonprofit in the area is Hospice by the Bay, that is now called Bay Area Health, but they are not in the East Bay. So we kind of partner together and talk about different program ideas. And we are similar in that we're a big nonprofit. I wanted to give, for those of you with pen and paper, and this will be online, this is our contact information should you like to reach out to us, either to understand who we are or to refer a friend or yourself for palliative care or hospice services. This is our phone number, and you'll be referred, or your information will be taken down and you'll get a phone call. I wanted to end with just some of my favorite resources. I feel really lucky to be a end-of-life practitioner in this era. And honestly, COVID has been so emotional. I was working a lot in the nursing homes when COVID hit, and it was just so difficult. And however, the silver lining is that we really partnered together to talk about what end-of-life care can be, what it should be, how to have discussions with patients and families, how to do grief processing. Living with uncertainty is one of the hardest things for us as modern humans, but it is something we need to get better at, because even though we think we're in control, as this pandemic has shown us, we're really not. And being able to not fight and push too hard against that is really important. So these are two of my favorite references that I refer patients and families to all the time. The Beginner's Guide to the End, B.J. Miller and Shoshana Berger out of UCSF. They're just fantastic. The language is very informal and funny at times, just walking folks through steps they can take, including life care planning, about thinking about how to live with serious illness and how to have the best life possible, knowing that your time is not infinite. And there are lessons in these books that we can all take from, because none of our lives are infinite. So whether we're living with serious illness or just living, again, I think planning for the end is really valuable. And Katie Butler's book is fantastic as well, very programmatic. She has stepwise ideas and just talks through options really thoroughly. And then I had two more. Ira Byock's classic book. He talks the four things that matter most. I have found them to be really true. It is to say, I forgive you, or please forgive me. I forgive you. Thank you. And I love you. And there is just something so basic about that. And sometimes I try and practice that every day, because it's true, not just at the end of life, it is true every day. And the Book of Joy, for those of you who have read this book, I think you'd agree, it's just full of life and laughter. And throughout it, because these two gentlemen are quite old, they're over 80. I think it's their mutual 80th birthday was the origin of the idea. They talk very much about living to your fullest, knowing that your time is short. So with that, thank you. This is the end of my talk. I wanted to make sure we had time for questions. Thank you for this time. May everybody be well. And the phone number I had put up for Hospice East Bay, you're welcome to call it. I'd be happy to just have further conversations, or if there's other places you'd like me to speak, I'd be happy to. Thank you.
Thank you very much. Thank you, Dr. Marquet. That was truly informative and really so important. And you actually covered a lot of important questions, and yeah, very good. And I can see that a lot of people have a lot of questions. You know,
Always, always.
we better get started with that, you know. So I want to say to everybody who wants to put who wants to write down questions, please put them down in the chat and not in the Q&A. It's a little confusing, you know, because we have to look into both then, you know, so please for today, put them all in the chat. Thank you. But I still will cover the questions that were actually in the, or are in the Q&A. I mean, they shouldn't be neglected. And so I will start with those. The first question was, what has your experience shown about circumstances where a POLST is available but not followed? And what things can I do to make certain the directions in my post are in fact followed? Can this be assured if, let's say, EMTs are conditioned, because, for example, EMTs are conditioned to preserve life and might not take direction from pink poles within sight? Let's say, for example, of wherever I've collapsed and found non-responsive.
Yeah, so fantastic question. I'm going to start by saying that you know, in the end, the post is just a piece of paper, probably sitting on your fridge. And I think it's a good question, and that it is important to understand that that's a pretty flimsy guarantee that your healthcare wishes are known and are going to be met. I will say, so the EMTs, fire, paramedic, have training after training about honoring the post. So I can't guarantee that a post is going to be followed if it's sitting on a fridge, but they are. Have I heard of instances of somebody's post not being followed? Yes, I have. And in fact, when I worked in hospital medicine at Kaiser, I have worked with families who come in and saying, what is my family member doing on a ventilator? They have a clear advance directive that they didn't want this. I think sometimes that there may not be time. So it's, I'm just being honest here, I guess. No, it is not a guarantee. Give it the best chance. Like my mom's, this is funny. I noticed it just the other day. My mom's post is so old. It is like bleached and kind of smudgy. And I need to get her a new one, because if I was a paramedic in the home looking at this thing that's a little bit illegible, I'm not sure I would feel comfortable following it. So the best chance of having a post be followed is stick it on your fridge, make sure it's nice, bright and pink, and let those people around you know that it's there, and that no, under no circumstances would you want to be resuscitated if your heart were not beating and if you were not breathing.
Thank you. So the second question is, what happens when the terminally ill person is able to state that she or he wants treatment that is different from what is stated in the advanced care document?
Oh, that's an easy one. If I understood the question, it's that, say I have documents in my file that say I would never want a feeding tube, for example. I've checked that box, feeding tube, never. But now I've had a stroke and I'm communicating. Maybe it's in writing, maybe I'm speaking, but my speech is slurred, but I'm still able to be understood. And it's clear that I am clear thinking. What you say is what is followed. So any written documents you have that say the contrary, if in the moment you are staring at a healthcare practitioner and say, I want that feeding tube. I know I said I didn't, but I want it now. That's what they will follow.
That's super.
And healthcare practitioners always ask, and sometimes they ask over and over again, I'm reading your healthcare file and it says you didn't want this or that. Is that still valid today? Because of course we know that these documents need to be living documents, and people change their mind all the time. And in fact, we all wish we had one idea, but sometimes we have different ideas, and people actually go back and forth with what they want. So healthcare practitioners really are trained to ask over and over. And for those of you who are sick of that, you're like, no, stop asking. I know what I want. Know that the practitioners are asking over and over again, because it's not uncommon for people to change their mind.
So if you have advanced dementia or Alzheimer's, can you request ahead of time that no efforts be made to provide nutrition? Seems like advanced dementia and Alzheimer's patients would have a difficult time qualifying for hospice.
So this is a huge topic. This is just a huge topic, and it's one that that we talk about the most among my colleagues, about supporting patients with advanced dementia at the end of life and what that looks like. Part of it is this work. Dementia has bloomed. The gray tsunami, there's different names for it, but the longer we live, the higher, or the more dementia we're seeing in our patient population. So it's new territory, and it's certainly new territory legally. People are starting to create documents that say, and you have to be very specific, if I have dementia and don't want to, and I don't recognize my family, and I don't pick up a spoon on my own, I don't want to be hand fed. So those documents are starting to show up. You can find them online. Some people create a narrative, either a letter, dear healthcare practitioner. The problem is, from the healthcare practitioner standpoint, because we know patients change their minds so much, it is very hard for a practitioner to be looking at someone and wonder, gosh, if they could have seen this today, getting good care, not in pain, would they have wanted something different? So these documents where people are starting to say, if I don't recognize my family and no longer participate in any activities and can't lift a spoon, don't feed me, the legality of those documents is not on solid ground yet. A lot of people are working to make it so. Compassionate Choices, and on their website, they have a dementia-specific advance directive. But legally, well, first of all, the person themselves will have lost capacity and will not be able to advocate for themselves. So it would come to their surrogate to advocate for them. And what I have found, my lived experience, especially here in the Bay Area, it's if a person has advanced dementia and is living in a care home with one of these documents, is to have a conversation with the facility. To say, look, this is what my mom wanted. I want you to honor it, and have that discussion. Of course, all of this it's very personal. And again, there's cultural beliefs, religious beliefs that play into this.
Another question about palliative care. Does palliative care require a terminal diagnosis?
No. However, that being said, say, for example, like multiple sclerosis in of itself is not a terminal disease. It's if a person is at risk of complications that then can make a person terminal, like bladder sepsis, wounds, or not being able to swallow. So in of itself, multiple sclerosis is not a terminal illness, but it's an illness that has a very high symptom burden. So that would be a great candidate to go to palliative care when those symptoms are building. So you don't technically need to have a terminal illness, but generally the specialty of palliative care is about symptom management. There really do need to be symptoms that the palliative care team are working with you to treat. Sometimes palliative care does do a first pass just of advanced care planning. There are programs out there where it is really more just about, oh, you haven't filled out an advance directive or have never had any kind of goals of care discussion. Let me do that with you. And it's kind of a one or twice meeting. Kaiser has that under the life care planning division. and UCSF has it under the social worker group.
And a question about, it's actually not so much a question, it's more a statement, and they would like, or the person would like your comment on it. Hospice care is not 24/7. Would you please comment?
Oh, absolutely. Yes, and I'm going to make a note to myself. I should add that to my slides. So hospice, I believe hospice is, we use the word assuming it's a certain thing, and it's very important to understand kind of what it's not. So hospice hospice is supposed to be 24-hour telephonic availability and the ability to get a nurse out to you within a reasonable time frame. Though I know there's always stories of somebody who felt that hospice didn't quite get there as fast as they wanted. But hospice is not like a place you go, nor is it the caregivers who come in to take care of you 24/7 at all. Really, hospice is a nurse manager and a social worker who will interact with you generally about twice a week for an hour during that time to check up on you. How are you doing? How are your medications? How is your caregiving going? The social worker can help you get caregiving, but hospice itself does not move in with you for 24/7. So in between the case manager and social worker coming to see you about twice a week, and that's not set in stone. Medicare, the regs say that that a patient needs to be seen at least once every 2 weeks. Some people are very private, and even though they love hospice support, they're still like, until I feel worse, I really kind of don't want you around too much. Other folks wish we could come every day, but in general, on average, I would say hospice case managers go out roughly twice a week. And then in between those times, there is the phone calls. What am I trying to say? Monday through Friday is our intake department, and then after hours is the call center to get a nurse out to the home if you're having problems. So it's access within 24, it's access to a healthcare practitioner by phone. But if it's after hours, say at like 2 a.m, it's true that it's not like there's a nurse right there within seconds knocking on your door, though we do our very best to get out there as quickly as possible, meaning between 30 minutes and an hour is our specific goal at Hospice East Bay.
So there are actually a lot of questions about your slides and if they are actually available for people. I mean, if you make copies available, I mean.
Oh, sure, I'd be happy to. Yeah, I mean, most of my slides are just pictures and then I kind of talk over them. But yes, absolutely. This talk will be shared, I believe.
On YouTube, anyway, yeah.
YouTube.
I think some people are just interested in the slides. So I think that would be Jessica then, I mean, to coordinate that.
Yeah,
okay.
Yeah, I guess for who's ever going to use them, if they could just be sure to credit Hospice East Bay, that would be great.
Yeah, I think it's more for personal use, because people really like the slides, I mean, that were the comments. So, okay, a question about hospice and Medicare. If someone pays for a Medicare Advantage plan,
yes,
would that person still get the full benefits of hospice under Medicare?
Absolutely, yeah. Whether you're what I'll call regular Medicare, though kind of nobody is anymore, everybody's Medicare Advantage, generally HMO Medicare. Yes, the hospice benefit is identical under both. Both.
And there's a special question about Kaiser. If on Kaiser Advantage, is palliative care covered with Kaiser?
Yes, so that's a good example of how palliative care is paid for. So if a person is Senior Advantage and has elected Kaiser as their healthcare provider to provide their Medicare care, you would have access to whatever palliative care Kaiser has to offer. And that's where, if you're Kaiser or Sutter, it might be very different. Kaiser and Sutter would have the same hospice benefit, but their palliative care would be internal to Kaiser or Sutter, and they're not the same, or UCSF. they're not all the same. That's where it starts to be confusing for people, is your neighbor will have one kind of access to palliative care and you have a different, and it's because it goes through the insurance agency that you're under, or the HMO that you're under. Kaiser actually has a very robust palliative care offering. In the hospital, it's fantastic. In the clinic setting, they do have a waiting list. There is more demand for palliative care than there is availability of practitioners. And that's pretty much across the board, across the nation. There's a real interest in getting the benefits of a palliative care specialist on your team to do all that I've talked about. But generally, there are waiting lists. And sometimes people would want palliative care just around, but palliative care will sign off if there's not a specific problem that they're managing with you, meaning either getting advanced care planning documents in order, or doing education on disease trajectory, or most commonly it's actively managing a symptom.
Okay. One question, actually, one participant was asking for examples of what is provided by palliative care, but I think that was pretty clear on one of your slides, if I remember correctly.
Yeah, I think the thing to remember about palliative care is it's a layer of support on top of your medical team.
Right.
So you have to have a primary care provider who is coordinating your care and providing the care. And then palliative care is like a subspecialty to that. Mm-hmm. And depending on where you are going to be getting your palliative care I can't, because it's not a guaranteed program, you have to find out programmatically what is available to you. And the best person to know that would be the primary physician that you work with.
Another question actually about hospice. Do you have to give up your personal physician when you go into hospice care?
No, and Medicare was very clear about that. So many of the ideals of hospice I thought were so smart. We really thought out back in the 80s when the benefit was being designed. And I think everybody acknowledges that this longstanding relationship you've had with a physician is something really, really valuable. And a lot of people want to hold on to that. So the hospice benefit includes a choice that a patient has to either choose the hospice medical director as their attending or to assign whoever they want. However, the rub, you have to make sure that your physician is willing to be your hospice physician, because there are issues that come up in the middle of the night and weekends all the time. And can the physician meet that demand? The other thing is, do they have the expertise? And one common scenario is where somebody does ask their physician to be their primary hospice physician. And if that clinician has experience, they say yes, but they'll say, but only Monday through Friday, kind of 9 to 5. And after hours, I'd like it to go to the hospice agency's physician. That's a common one. Another one is where your primary care physician will say, I'd love to philosophically, and let's stay in touch, which you can definitely do, but I don't have the expertise to actually manage this level of pain or this level of shortness of breath.
That is actually, I think, a very interesting question. Are there hospice care options for solo agers who do not have living family members for them to receive hospice services in a venue where they are not so isolated?
Oh, what a great question. Man, that's on my wish list for sure. That is on my wish list. So, hospice is not a place. So for solo livers, for people who live solo and don't have a lot of community around them, hospice can definitely add that layer of support in your home. But if you were sharing that sentiment with your case manager and social worker, they would probably recommend that you consider something like, well, what about a board and care that works closely with hospice agencies, of which there are many in all parts of the country and certainly here in the Bay Area. But for a person who wanted to live alone and stay in their home alone and have hospice support at a certain time, because most of us, before we die, we become bedbound. Sometimes it's for weeks and months, and sometimes it's just days. But at the end of life, there's a lot of care needs that the body needs that a caregiver would have to would be something that would need to be planned for, or that we would recommend plan for, because there's going to come a time when you're not able to, get to the kitchen, get to the bathroom, and you're going to need more physical care support.
Somebody asks, at what time should one have a post?
So my favorite use of the pulse, I don't put a pulse are really, really important, but it's not like a pulse can totally explain to the world what you want for your healthcare directives. But for somebody who doesn't ever want to go on a ventilator, if their heart stops or they stop breathing, they should have a pulse, even if they're, 20. People might say that's weird, but anybody who doesn't want to have an intervention done to them, I would recommend that they have a pulse. And ideally, when a pulse gets created by us, it should be a physician is involved because they have to sign it. There should be a discussion to explain the different categories of the pulse, so that it's really clear, so that there's the best chance that the pulse reflects what you're trying to say. And I find the pulse is most effective when it's really just trying to say, I don't ever want to be on a ventilator. If somebody comes into my home and I have stopped breathing, I don't have a pulse, let that be my natural death. That is when pulse can be very, very effective. Mm-hmm. And I'll tell you, because I speak to the first responders, or I certainly used to all the time when I was a hospitalist, and they love pulse. They're very happy to see it, because when they walk into the home, you kind of get a sense if a person is elderly and they clearly have died. The paramedics really go looking for that pulse, because they know, and they know the communities that they work in. They know that a lot of folks have said, no, there's certain things I just don't want. So they do go looking for the pulse on the fridge. I recommend put it on the fridge.
There are actually quite a few questions about dementia and Alzheimer's, and what end of life options are there for dementia? There's one question that came up a couple of times.
Well, and so dementia, and again, it's a whole talk. It's a whole talk, if not like 10 talks. And I want to go to them too. I mean, we're all learning, we're learning together. But I do work a lot with dementia patients. And one of my, when I do talk about dementia, there's stages to it. So we really need to start being more specific in our language. There's early dementia when a person actually has capacity. They may not be as functional or capable in a work environment. It may be hard for them to have instant recall of recent events, but they do have capacity and they have all the options that anybody else would have. If we're talking late dementia, on the other hand, where a person is not able to demonstrate that they have good judgment, that they are able to make complex thoughts, taking into consideration options and to weigh them. If a person is not able to demonstrate that, then they're not considered having capacity to make complex medical decisions. And then it's their surrogate who will speak for them. Now, their surrogate still has access to hospice, palliative care, full treat, do not resuscitate. The surrogate can declare all of those options for them. Not for voluntary cessation of eating and drinking, right? That's a very complex process that nobody can do if they have cognitive impairment. And also the person would not be eligible for the California End of Life Options Act. The law is very specific that a person has to have capacity to make all the appointments, all the decisions, all the steps.
Another interesting question, is an advance directive reviewed and used before doctors perform surgeries?
Oh, that's an interesting one. Uh, you know, part of this movement around advanced care planning is to involve the person, you, and your advocates, because no, sometimes healthcare gets it wrong and they don't review the file as thoroughly as they should. And I'm just being honest. However, things are changing rapidly, and the standard of care is really that advanced care planning documents are at the front of a person's file. My brother-in-law registered for surgery at Kaiser, and he was really taken aback at intake. There were more questions about, do you have an advance directive? Where is it? Who is your spokesperson? Than he had anticipated. And he was really thrown off by that. But the standard of care is really to review advanced care planning documents with every encounter, certainly for surgery, yes. Are there mistakes made in medicine? Yes. So the best chance for you as an individual to not be that 1 in 1,000 mistake, or however often it's happening, I can't say, is for you yourself to advocate to make sure that your documents are up to date and that the people are asking you about them, being like, hey, do you know, do you want to ask me questions about my advance directive? Do you have it? Can you show it to me? Let's make sure it's the right one. And it's the whole advance directive movement has really been from the ground up. It's been from communities like Ashby Village saying, hey, we really want to make sure that we are driving the boat in our healthcare, including our desires for or against certain treatments.
There's actually a somewhat critical question or critical comment and question, about hospice. Can you address how much help you should expect from hospice when your loved one needs supervision at night to stay safe? Also, in my experience with my mother, many of her medications are not covered by hospice, but are still meds she needs to be on for
Yes.
quality of life. I feel sometimes hospice is presented as handling everything your loved one needs, but I'm not finding that to be true in my own experience.
Mm-hmm.
So,
No, and that's honest. I don't take that as a criticism. I think understanding what hospice is and isn't is very, very important. So to the first one, the caring for somebody with symptoms at night. Again, hospice is the care. It's the nurse and the physician who are overseeing the care. Hospice is not personnel who will come and do the caregiving. So a person with symptoms at night, hospice will be able to address the symptoms, like, is there pain? Is there shortness of breath? A common one is dementia patients with a lot of delirium or sundowning at night. And I think, of course, people wish that hospice could just come in and help, kind of like sit with the person and help with those symptoms. But the caregiving, meaning the sitting with, the holding hands, the getting a glass of water, the walking to the bathroom, the adjusting the blankets, that hospice will not do that. That is true. They will work on a medication regimen that could help with symptoms, but they will not do the bedside caregiving. That is true. And that's at night or day. That's really kind of, the caregiving is the responsibility of the family, or whoever is caring for the patient. And the second part about medications is a really good one. The Medicare benefit covers medications as they relate to the terminal diagnosis. So if I'm a breast cancer patient who is now coming onto hospice, I've exhausted my treatment options and I'm coming onto hospice, but I have pre-existing gout. I've had gout since I was a kid, or say rheumatoid arthritis. I had rheumatoid arthritis from a younger age, and I'm on methotrexate or an injectable immune modulator. Those medications from rheumatoid arthritis are not part of my breast cancer diagnosis and are therefore not covered by hospice. However, they are covered by my Medicare Part D or my private insurance. So however I was getting my methotrexate before hospice, I would continue to do so. But the cost of the medication would not be included or would not be paid for by hospice.
Thank you. That's also I think that's an interesting question. Your medical provider will give info for various hospice providers. Should the family evaluate at least, let's say, 3 providers? How to best gauge which one to select?
There's a lot of choice in hospice agencies, and that's a tough question to answer. And only because I moved to Florida and I need a hospice agency, and I would be thinking the same thing, like, well, how do I know which one is best? I certainly would ask my community and saying who has had a positive experience with which hospice. I would ask my doc if they had a specific hospice they'd have positive experiences with. There are some ratings online, like there's this thing called the STAR report. It's a quality report that tries to give a number. It's like for nursing homes, hospice has a similar database, nationwide database. But I would say, like for most things, I would ask my friends and family who they've had a positive experience with. But you're right, because they're not all the same. They're really not all the same. And sometimes it's just like a feel thing.
There's one interesting question about the digital era we are in now. So is there a digital site to store wishes that can be accessible anywhere, if not at or traveling, or family can access? I mean, I assume it's about end of life,
Yeah, interesting. Well, there's certainly, just plain old Google Docs. It's in the cloud, right? Like we all have access to Dropbox and kind of online tools that are accessible wherever you are, and the documents would get scanned and then uploaded. So you could create a Google Doc. I know I'll share what I've done with my mom. I have a sister and my mom. And my mom is not tech savvy, but my sister and I are. We've created shared documents. So it's a Google file and they're shared between my sister and I have to say both of our husbands, because you want redundancy in the system. And in that Google document, we have copies of my mom's advance directive, a document we created that is kind of her first person narrative of more goals of care discussions about where she finds meaning and well-being and where she would not want to be kept alive. And those documents live online in a Google document. I don't know if you're asking if there's special websites and because there actually there are.
Yeah, I assume the question was if there is something kind of like official, that could.
No, there's not like a registry where you can register your documents.
I assume that was the question.
And there probably won't be, and I'll have to say, because there is a lot of fear that documents will be recorded that are outdated, because these are considered living documents. They need to be updated. As your ideas change, you need to change them.
Well, we are almost out of time, and I just want to ask you this last question, because I think that's also important. What services does hospice have for a surviving teenager when a parent has died? And are there any?
Oh, that's great. That's a really great question. So bereavement services is actually where the different hospices can actually show a lot of difference. A bereavement offering is a Medicare mandate. We're required by all hospices are required to have a bereavement offering. But how robust is that bereavement offering? That is where I personally, in my small 20 years of lived experience, have seen an enormous amount of difference. Because you can have kind of like token bereavement, or you can have specialty bereavement where you have offerings for small children, offerings for teenagers who are really their own bucket, for spouses, for other surviving family members. Some bereavement programs have groups where they offer kind of informal groups and specific ones, surviving husbands, surviving wives. And I have to say that is partly what drew me to Hospice East Bay, is they have a fantastic, the best bereavement group I've ever worked with. And we do have a specific program that works with teenagers, because that group is so specific. And unfortunately, cancer does claim some people when they have teenage children. So that's a great question. And it's one that you could specifically ask when you're looking into different hospices, is to say, tell me about your bereavement program. What will it look like?
Yeah, I mean, we are almost out of time. And first of all, I
Yeah.
mean, thank you so much. Thank you so much, Dr. Marquet. I mean,
Yeah.
for being so generous with your time, you
Oh,
know.
this has been a pleasure. Again, I
all
just
the
love,
questions
this is how we all get better at the work, is by sharing ideas and being fully transparent and honest.
Yeah. And unfortunately, we couldn't answer all the questions. So, but there is the YouTube presentation available, you know. So, yeah, again, many thanks. And I give it back now to Roberta.
Thank you all.
Roberta, you're muted. You're muted, Roberta.
Got it. Okay, sorry about that. Yes, thank you so much, Dr. Marquet. I know how busy you are these days, and I really appreciate your taking time to come and speak with us and give us such a really informative presentation. And Ashby Village will follow up on some of the questions and concerns that our members have expressed, and hopefully we can continue this discussion. I also just wanted to mention a couple of things. One is that in terms of the POLST, that's P-O-L-S-T, some of you are asking about it, physician's orders for life-sustaining treatment. It's also important to give a copy of that to your doctor, so it's in your medical file as well. And as Sigrid said, any of you who came in late and missed the beginning of this video, and I think some of you have, you'll be able to see it on YouTube. And I wanted to answer a few questions about healthier aging. There was one question about online classes continuing, and that is under discussion now. We are thinking about hybrid classes. We haven't come to any definite decision, but we are discussing how the classes will continue as the pandemic winds down, and we'll let you know about that. Want to repeat that Louise Aronson, some of you wanted to know the date again, that will be on March 27th from 2 to 4. And then there was a question about whether non-members could come on our hikes. And yes, you are absolutely welcome to join us and bring a friend along. We hope you'll come and take some of the hikes with us. But if you are actually interested in engaging further with our Healthier Aging program, we would like you either to volunteer or become a member of Ashby Village. And I think that answers the questions about healthier aging. So again, thank you all for joining us today. I thought this was an absolutely great and really important discussion. Jessica.
Thank you, Roberta. So I just wanted to welcome anybody to check out our YouTube later on, as Roberta mentioned. And also, I've gotten a lot of questions about saving the chat, and we were trying to accommodate that, and it just didn't work for this webinar. But the chat will be